স্যার শুনতে পাচ্ছেন তো?
হ্যাঁ, শুনতে পাচ্ছি।
So actually today our two chairpersons, Professor S.M. Nasir and Professor Prabhadoti Mondal, both are attached with CNMC, Calcutta National Medical College, and there was a sudden or emergency MCI visit in that college. So both of them just now called me that due to this emergency MCI visit, NMC visit, they cannot attend today's program. So without any delay, we will start today's program on behalf of Rohan, can you start recording?
Yes, we are recording.
Okay, thank you. So on behalf of Indian Pharmacological Society West Bengal Chapter and Inovocare Academy, I welcome you all in this academic feast. And today we have a broad theme, that is pharmacology and drug safety. And we all know the very initial mantra given by Hippocrates, primum non nocere, above all do no harm. So this is a very important topic, I think, and we are really fortunate today to have Dr. Chiranjib Bagchi, who is a clinical pharmacologist, a noted clinical pharmacologist in West Bengal and very well known in the field of clinical pharmacology all over India. So after Professor Shantanu Kumar Tripathi, who had done his DM in clinical pharmacology as a first time from Bengal, then Sir Dr. Chiranjib Bagchi sir is the second man, and with another colleague of him, in Dr. Indranil Banerjee. So we are really fortunate to have Dr. Chiranjib Bagchi sir with us. So welcome, sir. So please start today's session with your very important lecture on clinical pharmacology as a specialty service in critical care. Over to Dr. Chiranjib Bagchi, sir.
Thank you, Shambo, for this nice introduction, and I must express my sincere thanks to the organizers, especially the Shambo and the organizers on the part of Indian Pharmacological Society. Actually, for giving me this opportunity to present this lecture on this topic, which is very close to my heart in this before this August audience. Actually, before presenting this topic, I can make this introductory comment that before joining in MES, I worked in a corporate hospital, a very state-of-the-art corporate hospital in Eastern India, and I established a clinical pharmacology service there way back in 2006. And there I have been given the charge of initiating this service in the critical care unit. And I also express my sincere thanks in this regard to Professor Dr. Abhijit Hajra, who was my guide during my MD days, because after passing my MD, I did this work. Subsequently, I did my DM under Professor Dr. Shantanu Kumar Tripathi, and eventually Sir was acting as MSVP in that institute, IPGM, where I did my MD, and Sir also helped me a lot in implementing this service there at that corporate hospital. And of course, the critical care consultant over there, Dr. Suresh Amasudban, I owe to him, who has taught me all these nitty-gritties of clinical pharmacology service in this critical care unit. So this is my acknowledgement, and next I am proceeding to this presentation of clinical pharmacology in critical care as a specialty service. So you all know that critical illness changes, actually the many pathophysiological, afford many pathophysiological changes which happen in human bodies, and that's why which alter the pharmacodynamic and pharmacokinetics of the drugs. And in fact, these changes occur in obesity, pregnancy, old age, and of course in the extremes of age, like young and neonates and infants who are also there is a comorbidity with the critical illness. So naturally, this kind of comorbidities like obesity and physiological conditions like pregnancy and old age, they can alter the physiological changes, as well as the simultaneous clinical illness must pose a challenge to this drug prescribing in this group of patients. And of course, the extracorporeal devices, we all know that in this we are very much accustomed with this procedures during this COVID days, that is ECMO and RRT, that is renal, the replacement therapies, and these types of devices are there. We often use are used often in critical care units. And so these kind of devices also alter the pharmacodynamics and pharmacokinetics of these drugs prescribed in the patients under these instruments and devices. So we need to take care of these issues as well as the patients of the critical care unit. We all know that they undergo many kind of therapies, like they are supposed to have some polypharmacies because of the prescribing from many corners of the consultants, and naturally there is every chance of development of adverse reactions and medications errors. So naturally this issue needs to be taken care of. Now, just have a look at the pharmacokinetic changes in the critical illness. We all know that this issue of pathophysiological reasons. There is a delayed gastric absorption naturally, which limits the gastric oral absorption of the drugs from the oral route, as well as there is a poor systemic absorption from the intramuscular and subcutaneous routes, just because of the poor peripheral perfusion in this group of patients. And the volume of distribution commonly increased due to the total body water is increases because of the capillary leak syndrome and resuscitation, fluid resuscitation of this fluid overload, and that may lead to the underdosing of the drugs. And decreased plasma protein often happens in case of the intensive care unit patients because of the sepsis, you all know. And this leads to the increase in the free drug, allowing the increase in the clearance transiently, and that may be due to the initial stage of the acute renal failure, and there may be increased drug clearance. So altered hepatic metabolism also happen there. You all know, decreased hepatic blood flow, cytokine storm, and fever. The hepatic metabolism may be decreased or increased, and that lead to the pharmacokinetic changes. And decrease in urinary clearance due to decreased renal blood flow, low GFR, acute tubular injury in advanced cases. That's why leading to the increased blood concentration, serum concentration of the drugs. Simultaneously, the pharmacodynamic changes are also there. That is, drug effect will be decreased from the increased volume of distribution, impaired tissue blood flow, and of course, that may be increased due to the failure to excrete, that is decreasing renal function. And there is also an added anticoagulation because of this additional, because of the sepsis, and may lead to the DIC. And so you need to be very careful while prescribing anticoagulants and antiplatelet drugs. And of course, there is increased chance of deep vein thrombosis due to the prolonged bedridden state of these patients, and sometimes we need adequate prophylaxis for the deep vein thrombosis. So naturally, because of this polypharmacy and because of these issues, there is every chance of drug-drug interactions, and that's why we need to. It has been seen that at least 11% of the patients admitted to general ICU may experience different drug-drug interactions, and that several reasons are there. That is polypharmacy, altered organ function, and of course, advanced ages are the risk factors. The drugs which are important in this regard are the potent cytochrome P450 inhibitor or inducers, like rifampicin, which is a potent inducer of cytochrome P2C9, and that leads to a decreased warfarin effect, while the inhibitors like metronidazole and voriconazole, that leads to the increased serum warfarin concentration, and that leads to the increased bleeding tendency. So I like to highlight a case study which I have encountered during my training out there as a clinical pharmacologist in the critical care unit, and I have detected this problem, and that was very much acknowledged by the critical care physicians and other physicians there. So you can see that a patient with ischemic stroke with limb paresis with history of SAB, subacute bacterial endocarditis, that's admitted to neuro intensive care unit, and he was receiving injection cefoperazone sulbactam combination plus metronidazole infusion, and he was prescribed with warfarin orally. Subsequently, he developed hematuria, and INR was prolonged. Treating physician then stopped warfarin. Hematuria continued for 1 day, then stopped after stoppage of warfarin. Again, after 3 days, warfarin was restarted by the physician because the patient needed it. but after 2 days, again, the same situation happened with hematuria and prolongation of the INR. So what is the reason for this hematuria? Of course, the blood concentration of this, as INR is prolonged, so naturally it reflects that warfarin serum concentration is increased. And what is the culprit drug? Yes, warfarin is the primarily culprit drug, but what is the reason behind it? As I have already explained, that metronidazole reduces the metabolism of this warfarin, so that leads to the increase of blood serum concentration of the warfarin, and that was the culprit agent. So what happened? The metronidazole was eventually stopped by my suggestion, and that led to the change of the overall regimen of for the treatment of the SABE, starting with ceftriaxone, vancomycin, and so. So these are the issues which can be taken care of very diligently by the clinical pharmacologist and his team with the medication reconciliation in the critical care unit. And antibiotic dosing is another important issue in the critically ill patients, because of the eventually high risk of infections. We need to prescribe antibiotics in the critical care setting more very frequently. And concentration of the hydrophilic antimicrobials may be increased because of the decreased clearance due to acute kidney injury. Antimicrobial concentration may be decreased because of increased volume of distribution, augmented renal clearance by the systemic inflammatory response syndrome, and administration of the intravenous fluid may be due to the increased renal clearance, and so. So often multiple other conditions influence pharmacokinetics, and ultimately what happens is the underdosing of the antibiotic. It's often predominant in the critically ill patients. So the drug dosing should be taken care of, and that's where it needs to be particularly important in case of the patients having renal disease. As we all know that in case of the general patients and elderly patients, we often follow this start low, go slow technique. But here in case of the critically ill patients with renal failure compromise, we need to take another approach like start high and go fast. Okay, and then administration of the, so it has been seen that is administration of the smaller doses that maintains more steady concentration in case of the time dependent antibiotics like beta-lactams, while in case of the concentration dependent antibiotics that which maintains a high peak and low trough, that is extension between the time of administration between the antibiotic dose with a high initial loading dose often comes as beneficial, and that approach has been taken considered and now been considered by the most of the physicians in the critical care unit. So calculation of the EGFR, you all know that is a very important task before prescribing any drug in the essentially CKD. There are different formulas that there. That is Coprobal formula, that is MDRD formula, the CKD EPI formula. There are debates which one is best, but traditionally Coprobal formula has been used mostly, but nowadays it is being said that MDRD or CKD EPI appears better in case of the compromised renal function. And that is a very good tool, and the clinical pharmacologist and of course this team can ensure the proper calculation of the EGFR and before doing this medication reconciliation in these patients. So dosing in the hepatic disorder is another challenge, and you all know that there is a Ronald formula of hepatic clearance that depends upon the hepatic blood flow and free blood drug concentration, as well as the intrinsic metabolism of the drug by the liver. And these drugs can be classified into three categories, like having the high extraction rates, having the low extraction rates, and the intermediate extraction rates. And in case of the high extraction rates that have been less than 40% oral viability, that is undergo very much hepatic metabolism, we can use this formula that is contained for formulating a reduced dose out of this normal dose, considering its bioavailability. And in case of the low extraction drugs, that is oral viability is much more in this case of drugs like ceftriaxone, clarithromycin, metronidazole. You have to follow this child-Cook's classification, and the measurement of the free drug level is very much beneficial here, as because the patients may suffer from the undue toxicity. So in case of the antimicrobials and sepsis, I have mentioned that is in case of the selection of the and dosing of the antimicrobials in patients with sepsis and shock is very much important, and that is that should be considered diligently, considering the potential sites of infection and whether adequate concentration will be achieved at the focus of the infection. For example, in case of the bacterial meningitis, Penetration of the most of the antimicrobials, including beta-lactams, into the cerebrospinal fluid is limited, and high-dose therapy is often recommended for this. A patient case. Casey is a 45 years patient with a history of renal transplant in 2012. He has presents with respiratory distress, hypotension, is emergently intubated in the ER and resuscitated with 3 liters of normal saline. Casey has NKDA and non-phenotypic diabetic acidosis and weighs 91 kg. Serum creatinine is presently 3.2 milligram per DL. His serum creatinine was 1.3 mg per DL in the last visit 1 month earlier. Now his EGFR is 21.1 milliliter per minute, but the treating physician considers administering cefepime, ciprofloxacin, and vancomycin. But what dosage is to be given? And this goal is to achieve the adequate therapeutic concentration so rapidly. So loading dose is preferable here. And recommended loading dose in case of vancomycin for complicated infection is seriously ill patient is 25 to 30 milligram per kg based on actual body weight. So loading dose can be calculated utilizing this formula. So now you can see here that is how this increase over fluid overload and in case of critically ill patient differs, and just make it different with the administration of the loading dose in this particular different group of the patients. Like here you can see when the estimated VD is only 0.7 liter per kg, you see here estimated peak concentration level is 13 and 21 with this 1 gram and 15 milligram per kg body weight actual body weight dosing. But when the VD increases to 1 liter, eventually this same concentration can be achieved with this 25 milligram per kg per actual body weight of vancomycin. So naturally it recommends that loading dose should be high in case of the vancomycin towards this 25 milligram per kg actual body weight in this critically ill patients. So what dose to be given, as already mentioned, that is loading dose followed by high loading dose followed by maintenance dose according to the changes of the variable kidney functions and therapeutic monitoring supplemented by this. This is a very important task, and that can be established by the clinical pharmacologist in any state-of-the-art hospitals, and that should be maintained by the clinical pharmacologist for proper dosing and guidance to these clinicians. So now this extended and continuous infusion of time-dependent antibiotics comes to the play. You can see that there are different types of approaches like loading dose followed by maintenance dose, intermittent infusion, extended infusion, and continuous infusion. And it has been seen for vancomycin that continuous infusion is better than this intermittent infusion and loading dose followed by maintenance dose approach. And in case of meropenem, several studies are there. In case of meropenem, it has been seen that 1000 milligram of meropenem every 8 hours as a 3 hour, that is 30 minutes versus 3 hour infusion, it has been seen that 3 hour infusion is better than the 30 minutes infusion in case of the meropenem. So this policy is being now adopted in most of the critical care units, and clinical pharmacologists and clinical pharmacists may play a very good role here to monitor this. Adverse drug events, you all know that these several adverse drug events can happen in the clinical this ICU critical care setting because of this comorbidity, because of the polypharmacy, because of the organ dysfunction. So here we should take care of this medication profile, should be reviewed for proper dose adjustments with renal supportive care, and of course the prolongation of QT intervals that should be taken care of by the clinical pharmacologist and clinical pharmacist to check for the ECG, and when it is more than QT is more than 500 milliseconds, so you need to limit the drugs which have some QT prolonging property to reduce the chance of prostatitis depointes. Adequate hydration with isotonic fluid and maintenance renal perfusion is very good first-hand effort to reduce the renal toxicity in case of the drugs having these posing these adverse drug reactions. And drug dosing is to be important in case of patients suffering having the undergoing hemodialysis and CRRT. And you all know that is CRRT, because of this high flux dialyzer, it removes more drugs with a high molecular weight. And so compared to intermittent hemodialysis, and the patients with CRRT needs actually higher dose during the CRRT. And it has been said that when this drug doses are adjusted by the pharmacist or the clinical pharmacologist, the physicians accept most of the time, more than 91% cases the physician accepts that recommendations, and that affords the cost savings in the tune of $2,400 for CRRT patients. So that's the most advantageous, reducing the cost and of the treatment as well as the chance of adverse reactions and improving the efficacy. So another point is that dose adjustment with obese patient. That is a very important point. That is a note that it has been seen that is more than 12 to 37% of ICU patients are obese, And in several strategies are being adopted. That is calculation of this drug dose in with the actual as per actual body weight. Some calculate the drug dose as per adjusted body weight utilizing this formula, utilizing these correction factors 40% because of the obesity. Or some prefer to use the lean body weight. Some prefer to use the ideal body weight utilizing the height. But it's been seen that is loading dose of the lipophilic drugs like phenytoin should be based on the actual body weight, followed by the maintenance dose adjusted based on the serum concentration. But in case of the hydrophilic medications with smaller volume of distribution and limited distribution to the adipose tissues, may be dose based of the adjusted body weight because of to limit the undue toxicity. Because actual body weight is more, adjusted body weight is smaller than actual body weight, and lean body weight and I'm saying ideal body weight is the lowest. So these are several scenarios can happen. If we adjust the dose according to the total body weight, drug is inappropriately dosed using total body weight, then dose administered to the patient and minimal distribution into the peripheral compartment because the hydrophilicity of the drug that lead to the supratherapeutic concentration, and that may lead to the increased risk of adverse events. So this is one scenario. Another scenario is that drug inappropriately dosed in ideal body weight. According to the ideal body weight, usually that dose comes in the lowest and those administered to the patient, and that is extensive distribution in the peripheral tissue because of the lipophilicity of the drug, and which can happen due to phenytoin. In case of the phenytoin and subtherapeutic lead to the subtherapeutic concentrations and increased risk of treatment failure. So these are the issues which can happen there in case of obese patient, and this point should be taken care of. What is the role of the clinical pharmacologist? You all know that is the identification of the safety issues related to the medication administration in acute and critical care, reporting and prevention, that is ADR monitoring, drug selection and dose adjustment, that is a very important step, and considering the pharmacodynamics, pharmacokinetics, and the organ dysfunction of the particular patients, and adjustment of the dose of the vasoactive medications and anti-dysrhythmic medications and life-saving drugs. Like in case of the sedative and hypnotics, analgesic, and the paralytic medications like this, you all know that is several group of drugs are used in case of the in critical ill patients to limit this controlled use of these controlled medications and to limit the undue toxicities. The role of the clinical pharmacologist is immensely helpful here, and the common drug, blood products, nutritional agents that are very commonly used there, and the adequate dosing and the composition of these products that can be checked and rectified by this clinical pharmacologist. Medication errors detection, reporting and prevention, that is an important step, and establishment of the therapeutic drug monitoring service here and teaching the students, pharmacists, nurse, and clinician, that is an important task of the clinical pharmacologist employed in the corporate hospital in charge of this critical care unit there to provide the clinical pharmacology service. Medication error, you all know that is very that is medication error are the most common type of medical error in the ICU, and that can happen in different aspects, different steps of the prescribed, starting with the prescription, transcription, preparation, dispensation, and administration. And it's important to understand the risk factors of medication errors to prevent further occurrence. Why ICU is unique? You all know that ICU is a high risk because the complex interventions from multiple healthcare professionals. That is very important. Multiple health consultants are observing the patients, and they are prescribing out of their own. And the clinical pharmacologist role is there to assemble all these prescriptions and make an uniform prescription, help the intensivist in following the same. And strategies of preventing medications errors in the ICU, that is medication reconciliation, I have already mentioned. We avoid verbal orders except in emergencies, avoid abbreviations like U for units, as they are that is instead of O, that is, if you use O, that means units should be written. U can be considered as 0, and that may be misinterpreted. You can see here the omission of this 0 here, that before the decimal point 0 should always be there to limit this medication error here. It can be considered as a 5 instead of 0.5. The physician intended to write it 0.5. Instead of writing 0.5, he wrote 0.5, but inadvertently, instead of 0.5, it can be considered at 5 mg. That would be definitely a toxic dose while using the digoxin. So, good roundabout technique, prescribing generic as well as the brands in capitals, and in case of the current date, that is CPOE, that is computerized physician order entry system, is very important to limit this kind of handwritten medication prescriptions and avoid the medications that are out of that. And the standardized protocols, the barcode technology, use of CPOE system, and adequate nurse staffing, intensive staffing, and you see in the many of the ICU, the number of the nursing staffs are usually frequently changed, and they are very young nursing staffs, and they usually being untrained. So that needs to be very much taken care of by these administrators and the clinical pharmacologist team. Through case study, that is very, I will touch upon this issue because this is the important thing. I found that is a patient, 63-year-old man with recent history of peptic ulcer, admitted to ICU, community acquired pneumonia diagnosed, receiving antibiotics, heparin. CECT confirms that there was no PE, that is pulmonary embolism. Transferred, the patient was eventually transferred to medical IPD. But on the day 4, he readmitted to ICU with hematemesis, hypotension, dyspnea. Endoscopy revealed bleeding peptic ulcer. Heparin then stopped naturally. Protamine sulfate given as an antidote as PTT was more than 150. Second, so as we see here, heparin was not stopped. Though the patient was shifted from the ICU to the ward, PE was ruled out, heparin was continued. There was a medication error definite, and that was because of lack of medication reconciliation. So that adequate medication reconciliation should be there, and that case highlights that medication error happened because of the lack of medication reconciliation. While transition of the patient from ICU heparin continued unnecessarily, PPI was omitted because though the patient was continued with PPI for prolonged period, and that led to the occurrence of this peptic ulcer and bleeding peptic ulcer that promoted, and failure to monitor the heparin with APTT, and that led to the increase in supratherapeutic level, that is more than 150 seconds. So these are the result of lack of medication reconciliation. It is definitely preventable, and key strategies are there. That is because despite of the best effort, medication error happens. So we have to stop the blame game, because we need to improve our work schedule, work culture. We don't need to victimize the persons who are working at the corner, because the work schedule in the ICU is very hectic. So we need to stop the blame game. Simple vigilance, standardized protocol, and think before act are the usual steps to for the success and for the implementation of the better therapeutics in the ICU. And it has been seen the specialist critical care pharmacist can make a difference, substantial contribution to resolve medication errors and helping achieve the best use of medicines for patients cared for the hospital critical units. And it has been published in the Journal of Critical Care. And this is the first study in the UK and published in 2015. So to conclude, clinical pharmacology specialty service is increasingly being recognized in ICU setup worldwide. Regular ward round and consultation by the clinical pharmacologist is the key, and that eliminate the extended physician work schedules and support care to the support to their demand and appear supportive to them. Computerized physician order entry is beneficial to reduce errors. The manual, in case of the manual and legible correct medicine order in generic and brand names in capitals. Implement support system like Lexicom. This is a very good software and app, and up to date. These are for the clinical decision making. And computerized intravenous devices, active participation of pharmacists in the ICU work schedule, and proper indent system, and of course medication reconciliation by the clinical pharmacology team and the therapeutic drug monitoring service. So thank you very much for giving me this opportunity for your patient hearing.
Thank you, sir. Thank you very much for this beautiful lecture. We all benefited by your lecture. There are very important inputs, and as their Professor S.M. Nasir and Professor Prabhakar Mondal sir is not present because of their NMC visit. Today we have with us Professor Nihar Vishwas, who is also a very noted clinical pharmacologist in the country, and he was the director of IGIMS Patna. So, sir, may I request, sir, if you have any comment on this topic, please unmute yourself and make your.
Yeah, thank you very much, Shambo.
You have to open your video, sir.
Acha. Okay. Can you see me? Hello?
No, sir. I think you need to open your video, sir.
Yeah.
Yeah, we can now see you, sir.
Okay. No, it was excellent lecture by Bagchi, Chiranjib Bagchi. But my suggestion is just, I have sent that message also. The speaker should say slowly. Means he speaks so rapidly and very quickly. Sometimes I miss some points. Otherwise, it was a very comprehensive lecture and highlight the important points, not to read and every slides. That presentation part need to be developed. Otherwise, very good topics and very pertinent and in time. And I congratulate all of you to start this session. And let us see the other topics. Okay. Thank you.
Thank you, sir. Thank you. We have Professor Krishnangshu Ray, sir. Sir, if you have any comment on this particular topic.
Can you hear me?
Yes, sir. We can hear you, sir.
No special comment. You see, so WHO has already declared the patient safety as a fundamental component of universal health coverage. So it is not a new input to the subject. It's not that. The role of clinical pharmacologists, as spoken by Dr. Bagchi, was absolutely clear. And where we do stand, that has to be identified and has to be implemented. And for that matter, our presence has to be felt by others. That is an important issue probably at this point of time. Thank you.
Thank you, sir. Thank you once again, Dr. Chiranjib Bagchi, sir, for this wonderful deliberation. So we'll move towards our next session. And for the next session, we are really privileged to have Professor Krishnangshu Ray, who is one of the father figure of Indian Pharmacological Society, West Bengal Chapter, as a chairperson. Welcome you, sir. And also we have Dr. Shormila Nath with us. Dr. Shormila Nath is the associate professor. She is the associate professor at Medical College, Kolkata. And Madam is also the Joint Secretary of Indian Pharmacological Society, West Bengal Chapter. Welcome, Madam. Please proceed for the session.
Thank you, Dr. Shambo. As I told to chair the session, most of the things have been already spoken by the previous speaker. Now, the present speaker, Dr. Subhrojyoti Bhowmick, he will be speaking on another aspects of it. Dr. Bhowmick is a colleague of mine, and he has been trained in patient safety issues from different institutes like Stanford University recently. He has been trained from Harvard. So he has ample knowledge, and we would like to listen from him. Before that, the one thing should be kept in mind that patient safety depends on fewer issues. Like our goal of treatment is three. One is it should be effective, it should be safe, and it should be people-centric. And the burden of harm when a doctor or health worker manages a patient, there's an enormous. There might be diagnostic error, there must be medication error, there must be therapeutic error, many other hazards. So Dr. Bhowmick probably will be highlighting those points, those aspects. And what I feel working in a hospital, corporate hospital, that everything which is required now is a clear policy for patient safety. Every hospital should have a clear policy and a good leadership. And thirdly, that the data which will generate out of this, because we learn from the mistakes, and whatever mistakes we commit, that should be documented and we learn from it, and further improvement can be made out of these mistakes. So these 3-4 things, probably it's a new subject altogether, and we have to learn much without wasting time. May I request Dr. Shormila Nath to give some touch upon some points on the issue, then we'll go to Dr. Nath.
Thank you, sir. Actually, you have touched all the points what I wanted to say. And one thing I would like to add is that I am very much honored to be the chairperson of this session, because Dr. Bhowmick was my teacher in the post-graduation days. And I'm a great admirer of his positivity, and he's highly knowledgeable, and I think he's the best person to give this lecture. So without wasting any time, I would invite Dr. Subhrojyoti Bhowmick to this session and share his knowledge with us.
Thank you. Good afternoon, respected chairpersons. I think it's an honor for me to be here at the West Bengal IPS Society's initiative to talk about clinical pharmacologists. I really want to first congratulate Dr. Samajdar, who has been playing a pivotal role in bringing the society's work so prominent. And I also want to thank Dr. Chiranjib, Bagchi, who's probably, I think, one of the first clinical pharmacologists we know has worked in the private sector, because when I was doing my post-graduation, I still remember I went to Chiranjib and asked him what we do about it. So today I'm going to talk about the presentation, and let me pull this presentation up. Just please let me know if you're able to see slides.
No, not now.
Is my slides visible? Are my slides visible?
Yeah.
Yes, yes.
Okay. Thank you very much. Thank you. So I'll try in the next 20 minutes to talk about this particular thing, which is really happening in India right now, which is the role of the clinical pharmacologist in Indian accredited hospital. And because I come from a private hospital, my discussion will limit to the private hospitals where this role is really evolving day in and day out. So the medical tourism industry is really on rise, and it has advantaged India. India's healthcare industry is worth $65 billion and is expected to grow around 13% over the next 5 years, where Indian healthcare industry will touch $150 billion. What does this mean? This means that the government has increased public expenditure on healthcare to 2.5% of the GDP from 1%. We have a lot of public-private partnerships in hospital infrastructure, and this is resulting in increasing medical tourism. That means patients from across the world want to come to India. Medical tourism could account for 6 to 8% of the total healthcare expenditure, healthcare delivery market in 2025. And why this is happening is because the Indian hospitals are charging 200 to 800% less cost for procedures like total knee replacement, total hip replacement, CABGs. So people waiting for surgeries in the UK, people waiting for CABGs in Singapore are actually coming to our own country. So this has resulted in boom of hospitals across the country. And if you can see, there are a few hospitals, one of them is actually mine, ours, I would say. Then this is so this congenial economic environment has resulted in the hospitals to, I mean, there are loads and loads of private hospitals which are coming up, not only in West Bengal, but across the country. So choosing the right hospital becomes a big question for the patients and their patient family. And accreditation is the key for choosing the right hospital, because accreditation ensures uniform standards of quality of healthcare. In India, the accreditation of healthcare services are carried out by NABH. And also NABH has an international wing, which is the NABH International. NABH, of course, NABH is actually the constituent of Quality Council of India, which is developed by the Ministry of Health. Ladies and gentlemen, NABH is an institutional member of ISQA. Now, what is ISQA? ISQA is actually the mother accrediting body of all standards across the globe. And NABH is an institutional member of ISQA since 2011. That means our standards are equivalent to the Australian standards. Our standards are equivalent to the American standards. So we are nowhere inferior to any of the international standards. The international accreditation standards, which are very commonly also embraced in the Indian hospitals, private hospitals, is the Joint Commission International. And very recently, the American Accreditation Commission International, which is another American accreditation body, has started accrediting hospitals in the country. So many private hospitals are in the queue who want to get these American accreditations on board. So if you look at the NABH standards, the hospital is divided into patient-centric standards and organization-centric standards. Because we are doctors, we will concentrate on the patient-centric standards. And one of the important chapters is the management of medication. And this is where the role of the clinical pharmacologist is required in the accredited hospitals. What is the job responsibility? Dr. Bagchi has mentioned about the job responsibilities, but let me tell you the main job responsibility is medication management. So you become the convener of the Drugs and Therapeutics Committee, which formulates policies and procedures to guide the organization of pharmacy services. You help in development or formulation of the hospital formulary. You formulate policies and procedures for storage of medication. Say, for example, remdesivir, how it would be stored. We needed to give some feedback to the pharmacy. You give policies and procedures for prescription of medication and to guide safe dispensing of medication. Policies and procedures for use of implantable processes. The very important function of the Drugs and Therapeutic Committee is that it is the primary or the pivotal committee for advising medical, administrative, and pharmacy departments on drug-related use. So as pharmacologists, you sit on these committees, you regulate, or I would say you facilitate the decisions of drug usage in the hospitals. You are a very important aspect in or a member in selecting drugs for the formulary and providing its periodic revision. So the pharma companies on a regular basis interact with you. You assess drug use for identifying potential problems. So the ADRs are actually presented here. And you also kind of look at medication errors which are reported in the hospital, and you do a root cause analysis and you develop effective preventive strategies. The other important thing, of course, I would say the pharmacovigilance, which is we are trained in pharmacovigilance. So in hospitals, in private hospitals, if you want to work in private hospitals, which are NABH accredited, you would require to implement pharmacovigilance. And this is, I think, a pharmacologist can do this really well, whether the MD and the DM course really helps us to understand the pharmacovigilance program of India, how it has to be implemented, what are the policies, procedures as far as the national program is concerned. Another very important program is the medication error detection and management, because medication error is a source of medical legal litigations in the hospital. The hospital also wants you to formulate procedures and policies for the use of narcotic drugs and psychotropic drugs, as well as for chemo drugs and radioactive drugs, which are very hazardous drugs in the hospital. Another important thing is that you take part in the hospital antibiotic policy along with the clinical microbiologist and the head of critical care. And you also lead the prescription audit team. The audit might be done by the pharmacist, but you lead the prescription audit team and you undertake drug utilization study. So just to give an example of what the medication error program was at or is still at Peerless Hospital, we have this form which we've implemented at our hospital, and people, that means doctors, nurses, and pharmacists, we've trained them, they report it, we look at the error, and then we do a root cause analysis and develop preventive strategies. The other important thing for the clinical pharmacologist is to play an important role in the clinical research activities of the hospital, because you would be involved in constitution of the ethics committee and conduction of the ethics committee meeting. At my hospital, I am the member secretary, and I must tell you my training in clinical pharmacology and in pharmacology, I would say, really gives me an edge over the clinicians to conduct this meeting more efficiently. We conduct GCP training programs for the investigators and ethics committee members, and as pharmacologists, we are trained to do that. We develop SOPs guiding the functioning and of the ethics committees. We take part in feasibility procedures. This, of course, is done by some of the members in my team, and we mentor clinical research coordinators for proper management of trials. So in the hospital, you can actually lead the clinical research department along with managing the clinical pharmacology department as well, because the sponsors are going to contact you because they really like a one-point contact in the hospital. They really don't like talking to too many clinicians. They are themselves confused. So if they have a person like a clinical pharmacologist in the hospital, they really prefer it. You are also supposed to facilitate quality indicators relevant to the NABH standards for management of medication and clinical research. So this is the list. I'm not going to go into the details of it, starting from incidence of medication error, prescription errors, adverse drug reaction, percentage of medication charts with error-prone abbreviation, percentage of patients receiving high-risk medications, developing ADRs, and compliance rate to medication prescriptions in capital. These are with respect to the ethics committee, and we look at percentage of research activities approved by ethics committees, percentage of patients, percentage of patients withdrawing from the study, percentage of protocol violation, deviations, and percentage of serious adverse events. So this is something which we routinely do in clinical trials. But if you're an NABH accredited hospital, you would need to capture these quality indicators as well. The other activities which can be performed by the clinical pharmacologist is drug information service, a very, very important service where the clinicians can call you up on a regular basis and ask for any new drug services, their pharmacokinetics, as well as their dosage details. And Dr. Bagchi really mentioned that the critical care physicians really fall back on you. Sometimes they really, really rely on you when they're using new drugs in the critically ill patients. And finally, I would say medical writing and publication. So just to showcase what we did as a group in one of my hospitals, we looked at the ionic contrast medium, the adverse drug reactions, which was found in non-ionic contrast medium. This we did in 2011, and we looked at over 3,700 patients, and we really found out that the non-ionic contrast medium was very safe in that particular hospital. We've also gone ahead and trained our nurses on pharmacovigilance, which has been published. And in fact, I'm very happy to share that this particular paper won us the Best Patient Safety Initiative Award in the Apollo Awards in 2014. And this particular article, which we have written, is about the role of the clinical pharmacologist. So even if you don't get my slides, if you Google this particular article, which is there, which has been published in the Journal of Pharmacology and Pharmacotherapeutics from JIPMER, talks about that this sector is evolving and we really, really need more clinical pharmacologists as far as the private sector is concerned. To summarize my presentation, I would say that clinical pharmacologist is a great link with the clinicians and the hospital doctors, the nursing staff on the one hand, the administration, because administrative, lot of policies have to be implemented with the help of the clinical pharmacologist, and then pharmacists, because I personally seen them struggling when they are at the ward, so we can help them as their mentors. So we are a bridge between all the stakeholders in a hospital, and we should be proud about it. But we need more awareness for this role, and I really thank IPS West Bengal branch to kind of conduct this session. And we are constantly working with NABH. I've been an NABH assessor for 9 years now, so that they endorse the mandatory clinical pharmacologist role in all hospitals. That will open the path for every clinical pharmacologist to get a job in the hospitals which are not taking them right now. But there are very many recruiters, Apollo hospitals, Fortis hospitals, Tata Group, and I would say any hospitals which have JCI or NABH accreditation will require clinical pharmacologists as one of their important team members to ensure patient safety. With this, I would like to end my presentation. Thank you very much once again for the opportunity.
Thank you so much, Dr. Shubhro. It was a highly enlightening session for us, because most of us, we are very, actually, we are not acquainted with this topic. And one thing I would like to ask, is there any government hospitals are following this accreditation policy? Because it is I think it is voluntary. And how we can proceed? What are some of the steps that we can take regarding this?
Can you repeat the question, please?
Actually, I am doubtful whether government hospitals can follow these accreditation processes, because I think financially there are some constrictions.
No, thank you for that question. And I personally would say that, there are government hospitals in the country who have gone for NABH accreditation. Unfortunately, not much in West Bengal. West Bengal has not done much. There is a lot of opportunity for West Bengal to do it. But you look at the state of Gujarat, Maharashtra, in the state of Kerala, in the state of, I would say, in Delhi, Uttar Pradesh, a lot of these hospitals, which are government hospitals, they have really undergone the NABH accreditation process. And NABH is not a very expensive proposition. The American accreditation program really is. I think there has to be an intention on the behalf of the senior administrators at the government level that they need to embrace NABH. The reason is because it will ensure standardization of clinical as well as non-clinical processes. And I would say that some of the government hospitals in West Bengal, they have gone for the NQAS accreditation, which is the National Quality Assurance System accreditation by the NHSRC, which is under the Ministry of Health. And one hospital I would really like to mention is the MR Bangur hospital, which has performed really well in the NQAS accreditation. So in West Bengal, the government hospitals are actually following up with a separate set of accreditation, but NABH accreditation clearly has a MOM chapter. And I think, as Professor Roy mentioned in the initial part, that we need to have our presence felt because NABH is directly related sometimes to the insurance which these hospitals get, the private hospitals get with respect to the billing. Many a times NABH has been more endorsed by the private sector. So there are currently, as we speak, there are more than 1,500 hospitals in the country, big hospitals, which have embraced full accreditation of NABH, and more than 3,000 which have embraced the entry-level accreditation. But I think we need to make a lot of noise. We really have to go to every NABH accredited hospital, take some, I would say, the students who are here, the postgraduate residents who are here, they need to take some chances, come out. I won't say leave government, but then come out, be in private, because they also need good people to run their MOM or the medication chapter. I'm sure the government of West Bengal, as they pursue for excellence in healthcare, will also embrace NABH in due course. And people like you, Dr. Nath, I think can play an important role for making the government understand that, yes, this is ultimately about improving patient care and nothing else.
Thank you, sir. Now
Thank you, ma'am.
I'll hand over to Dr. Shambo for the next session.
Thank you. We are really delighted to have Dr. Subhrojyoti Bhowmick. Thank you very much for giving us time. So one thing I just want to ask you, or what is your opinion regarding that during our course curriculum that is in the DM Clinical Pharmacology course curriculum, specifically our Professor Shantanu Kumar Tripathi sir always give us two tasks and give us importance on two aspects. One is assess the risk, and finally, if there is, when the risk is converted to any harm, then how to manage that harm. So there is two important aspects. That is, one is drug-induced disorder and how to prevent that drug-induced disorder in hospital setting. So sir actually used two terms. One is clinical pharmacological reconciliation, review, and feedback in some patients. And number two is when there is some drug-induced disorder, often known as iatrogenic disorder. So he always tells us to check every disease, every disorders when we are going to see any disorders. So make drug-induced disorders as an important differentials, so that we can approach to that, we can diagnose it, and we can manage that. So what is your take on these two aspects as a role of clinical pharmacologist, even in private hospitals?
Yeah, so I mean, I completely agree with Professor Tripathi. He is my teacher too. So I would say that, yes, what he's saying is absolutely correct, because ultimately the private hospitals really, they also are learning about this role. The role is not very new. It's probably a decade-old role. So medication reconciliation is an important requirement for the accreditation process. And as I mentioned, that the clinical pharmacologist will be part of this medication reconciliation process, along with the nursing and the medical fraternity, the doctors. So yes, it is being implemented because it is checked when the assessors or the surveyors come to assess you, because if you don't do it, you don't score on that pattern. That is one aspect, definitely. The other one is risk management. Is you for iatrogenic or the iatrogenic causes. So if they would really like to look at your ADR monitoring system and how many ADRs are you capturing, whether errors and ADRs have a correlation. So this is a mandatory requirement to get accreditation, because if you don't score, so as I mentioned, you have chapters, within the chapters you have standards, and within the standards you have elements. So one of these standards is dedicated to medication reconciliation. And if you have to achieve the standards, you need these objective elements. So there are 4 or 5 elements which you need to implement, which is actually nothing but the entire pathway of medication reconciliation. And exactly similar happens for risk management with respect to the drug-induced iatrogenic diseases. So it is required, but if you ask me that whether the hospitals understand this or not, the answer right now is still 90% of the private hospitals don't understand it. They do it because they have to do it as it is a mandatory requirement for an accreditation process. I think we need more communication, more people, if I would say in the private sector, who have embraced this particular role and are speaking openly that yes, this is required for patient safety, because government setups definitely have the academic support, like people like you, Professor Tripathi, Professor Roy was in School of Tropical Medicine, and then of course at Shastro Bhavan. So, but the private sector is lacking in this. So if I today as we speak, we hardly have 10 or 12 doctor clinical pharmacologists who are working in at least 1,000 accredited hospitals. So that is a very depressing scenario. But I think I don't look at the depressing scenario. I think there is a lot of opportunity for 900 more hospitals to absorb 900 more clinical pharmacologists if they go, they talk. And that is the reason one of the slides I mentioned, it has to become a mandatory position like the medication safety officer, as NABH has the hospital infection control officer as a mandatory position. If we can do advocacy and lobbying with the NABH that yes, a medication safety officer is a mandatory requirement, then I will tell you that these 1,000, 1,500 hospitals, we are going to, and every one of us are going to have 7, 8 hospitals to get attachment for. So I am really requesting IPS West Bengal branch under your leadership and Professor Mondal's leadership to do this advocacy with NABH that they should ensure that the medication safety role should go to a trained doctor. They will not, they have refused, saying that there are not so many clinical pharmacologists, MD or DM trained in India. So 1,500 hospitals, how will they run? So at least a trained professional should be there who is trained in medication safety, because this is a huge job opportunity, huge job opportunity for our younger generation to come. So again, to answer your question, absolutely, these two are very important, as highlighted by Professor Tripathi, and is being done for the accreditation purpose in this accredited hospital.
Thank you very much. Actually, we need you to actually help us in this project, because your guidance will be most important. And also on behalf of Indian Pharmacological Society West Bengal Chapter, we want to thank you. Also, we want to congratulate you, because you are the, I think, the first certified in patient safety from the premier institute of USA, that is Johns Hopkins University. So congratulations.
Thank you. I think for us, our career is over, Shambo. I think very importantly, the students who are hearing me, if one of you want to join private sector, please get in touch with me. It's not that bad. It is a good sector. We need to prove our mettle like any pediatrician or any radiologist. Let's prove our mettle, and we have a lot of opportunity here. Let me tell you, people are looking for good talent. People are not getting, so they are going for PharmDs, they are going for M-Pharms. I am not demeaning anybody, but actually, this is our role. If the psychiatrists don't treat patients, then ultimately they will be forced to call clinical psychologists to see these patients. That is what is happening in our scenario. So again, Shambo, thank you very much. And Nihar sir is here. My regards to Professor Nihar Ranjan Vishwas sir. You are a father figure to us. Thank you very much. Namaskar to you. Namaskar sir. Namaskar. You have done a lot for our fraternity. We really are proud of you, sir. And thank you very much, sir, for everything for the fraternity.
I'm listening your lecture. It's very encouraging and good positive impact to our clinical pharmacology students. Thank you.
Thank you, sir. Thank you.
Thank you. So we have to move towards the next session. And before that, we are really privileged to have Professor Partho Ray from UK. So Professor Partho Ray is one of the very a prominent neurologist in India, and also he is now in UK. So may I request Professor Ray to have his comment on how his experience, actually, if you can share your experience on patient safety in UK and how that can be translated in Indian context.
নমস্কার সবাইকে। I am from Kolkata, Calcutta Medical College, 1991 pass out batch. Thank you, Shambo, and thank you very much for inviting me to the IPS program. You just gave me 3 minutes, 5 minutes notice to talk about patient safety experience. Thank you for that. I like getting stumped, so I made some notes. Right, about I've been watching the evolution of patient safety agenda in the UK since 1994 till date. And this has also been a turbulent experience for UK physicians in the last 29, 30 odd years that I've been seeing the greater emphasis of patient safety, that is everybody's right whenever is a patient to receive safe and quality care, evidence-based if possible, from the treating physician, however senior or junior that person might be, because often at night it's the youngest and the least experienced doctor who treats the patient for emergency care. We all come in next morning. By that time, usually the good is done, and sometimes some severe damage is done. So we just heard about Johns Hopkins. There's a paper which says that in US, the third common cause of mortality is medication errors and procedure-related complications after, I think, cancer and heart disease. Please correct me if I'm wrong. So all I'm trying to say is that patient safety drug errors are often not declared or documented as honestly and as widely as they should be. So it's time to save lives and learn from our mistakes. That's very important, because with the whole world population not having enough number of doctors globally, and the situation is extremely dire in India from a population to nursing ratio, because our nurse didis are the ones who give the medications, and population to doctor ratio, because it's us who write illegibly medicines and they can often get distorted, including the prescription legibility issues. So doctor tiredness is a very important factor we have got to consider, and leading to drug errors. Handwriting and drug legibility is very important, which is why in UK we have moved on to e-prescribing, and that should now come on. We have heard a lot of discussions about the private sector and the government sector, but it's all, I could land up anywhere, and I deserve the best care in India. Doesn't matter where I go. So there's no difference. Healthcare in India should be across the board uniform. Then again, I have had apps here and e-prescribing strategies, which give me drug interaction prompts or alerts whenever I'm prescribing one drug. And my doctor, the general practitioner, always gets drugs alerts whenever it's prescribing something with a potential, just as a reminder. And I've raised this in different forums. Be brought into widely anyone, so that prescribing as well as alerts for doctors whenever they're prescribing something wrong. Now, prescription of generic medicine is rolled out in UK, although in India I have heard and I've seen both branded and generic, and there's a very big difficulty about names, similar sounding names of drugs, causing medication errors, and that will contribute towards patient safety issues. And of course, many over-the-counter prescription habits needs to be stopped by the Indian population as well, because they are taking their lives into their hands, and often the dispensing person is just not a pharmacist. I'll come to that in a minute. And I had a good talk. The very first talk was very, very loaded, very, very informative, slightly fast, but packed with information. And that raised to me the very complex situation that we have in ITUs. And I insist that in ITUs, we have a clinical pharmacologist doing the rounds twice a day to check on drugs, do drug monitoring, doses, legibility of prescriptions. But now we are moving on to e-prescription. I'm giving you a blend of what I've seen in India and what I've experienced and practiced in England to make some sort of bullet summary points for possibly people who are younger than me, who will be leaders for the future to take these things forward. Now, drug safety, we need policies and procedures and a very clear governance policy, which should be done yearly in every institution, be it government, be it private, be it a private chamber, wherever, because we have to be very alert. Because whenever we give a registration number to a doctor and a piece of pen and paper, we are basically giving him a sword to uphold the justice or cut off somebody's head without even knowing. It's a dangerous weapon, this pen. It can work both ways. So that's why it's very important to write the right medicine in the right dose, in the right name, preferably and possibly generic all the time. And all hospitals should have a duty of candor. Candor means honesty. If you have a drug error, if you made a mistake, tell the patient about it. That way, our trust between our society, patient, and the doctor will be built up. Everybody is prone to make mistakes. As long as we honor it and declare it at an early stage and learn from it. And we have here various different monthly morbidity meetings and mortality meetings as part of patient safety. Surgeons do mortality, we do morbidity. Most of our patients don't die through any errors or any procedures. They die when they have an incurable illness, most times. So I think that helps. Now we have here the General Medical Council website, and only yesterday somebody was querying my Indian credentials. So I went to the NMC, National Medical Council website. It should be well constructed, better constructed, with lots of hyperlinks and things. I would invite somebody to look into it. I have seen the West Bengal Medical Council website. It's better than the NMC website. So just a feedback to NMC people, please develop it, because the whole world with the medical tourism is looking at India and about the accreditation that we have among us who want to provide fee for service at 800 times less rate. Important that we build up our own front window properly so that people can see who we are. Our nursing didis have got to be very much well trained, and they work far harder from what I've seen during COVID times. And so they are the ones who are giving the medicines, whether they're checking the doses, the names, and the dilution and all these things, very important in the emergency as well as on the ITU. Our pharmacist colleagues need to help us. I don't think you will ever have enough clinical pharmacologists running the drug discovery or assessment. Our pharmacists, and that's again a shout out to a younger population, we need a lot more allied health professionals, pharmacists, to give us the backup. There will of course be a clinical pharmacologist who will be doing ward rounds on ITU, but general checking of every prescription that goes through it, including electronically, should be the norm. I heard about the variation of standards across India. It has to be a government of India central government initiative. It has got to be rolled out to the state level because health is a state subject. And why Maharashtra, West Bengal, us can make West Bengal just as good or be a model for the future for doing clinical pharmacology and patient safety as the the national leader for all states. We can do the turnaround very quickly. We just need the initiative and the right people at the right places, and everything is easy to follow. The internet has been a big help to all of us. We can copy and paste lots of things from other working organizations, the FDA website, the European Medical Commission website, the General Medical Council website are a wealth of information for patient safety. For me, I think all our knowledge, all the decades of hard work we do, all the Harrisons we read for 4,000 pages or whatever it is in the current edition, has got to eventually translate to good care, evidence-based care, and safe care for myself when I get old, or even now, and for my parents if they were alive, and for everybody, from the top person, President Mumu, to the last person living in my village miles and miles away from the nearest health center deserve equal care. Maybe not today, maybe not in 5 years, but maybe in 2030, and most definitely by 2047. We need to provide that service to them. I think patient safety is paramount, and thank you for giving me the opportunity. Jai Hind.
Thank you, Professor Ray, for your insightful talk. So we are actually running short of time, and we have to move forwards towards next session. And for the next session, we have chairpersons Professor Indranil Vishwas, who is the principal of Bankura Sammiloni Medical College and professor of pharmacology, but he had a emergency meeting at Institute of Health Research, that is in Shastro Bhavan. So he had to leave. So also we have Dr. Subhash Mondal, who was the formerly Deputy Director of Drug Control of Office of Bengal. So he had a message for us. May I request Rohan to please start that recording, and then we'll move forward towards the scientific session. We have our faculty, Shatavisa Mukherjee, who was formerly assistant professor of pharmacy at different colleges, and currently is a PhD scholar at Department of Pharmacology, School of Tropical Medicine. So let's hear from Dr. Subhash Mondal.
Good afternoon, everyone. At the outset, I would like to thank the organizers for giving me this opportunity to send my message in the CME on pharmacology and patient safety, especially on the.
Is it visible?
It was visible and audible perfectly. Please start like previously.
Session entitled Medical. Good afternoon, everyone. At the outset, I would like to thank the organizers for giving me this opportunity to send my message in the CME on pharmacology and patient safety, especially on the session entitled Medication Safety, Integrating All Stakeholders. The topic has been chosen very rightly, as a recent study reveals that medication error is the third largest contributor in case of death after heart diseases and cancer. The magnitude may be clear with the data that about 7.7 million patients hurt every year globally. It involves economic consequences like extended hospital stay, additional treatment, etc. Medication may occur due to prescription errors, administration error, transcription error, and dispensing error. There are several causes of medication error like illegible handwritten prescriptions, wrong dose, especially in case of child below 15 years and elderly above 65 years. Sometimes half of the adult dose prescribed for children in spite of calculating dose on the basis of microgram or milligram per kg body weight, leading to overdosage. Other examples are use of wrong abbreviation, for example, confusion between milligram and microgram, not using zero before decimal, etc. Look-alike and sound-alike drugs are also a common cause of confusion, leading to medication error. Besides all stakeholders, pharmacists can play an important role in reducing medication error in case of dispensing, compounding, patient counseling, and they are doing so efficiently in institutional setup, but high patient load for pharmacists is a deterrent here. In our country, a major portion of the drugs are being dispensed from retail medicine shop on prescription of registered medical practitioners or as self-medication, where the role of pharmacists is immense to reduce medication error. Therefore, pharmacists should update themselves serious in dispensing and be present in the community pharmacy as long as selling activities is conducting. Finally, I would request all healthcare professionals and the patient be careful about this issue as patient safety is everyone's job. Thank you.
Thank you, Dr. Subhash Mondal, sir, for giving us your time. Now we have to listen from one of the prolific speaker in IBS Bengal, that is Shatavisa Mukherjee, who is also a PhD scholar of pharmacology at School of Tropical Medicine. Over to Shatavisa. Your slides are visible.
I hope that I'm audible too.
Yes, yes.
Thank you. Very good afternoon to all the participants today. My sincere reverence to all the members of Indian Pharmacological Society, my seniors and my teachers. I'm very thankful to this platform today, actually, for allowing me to speak on this topic, which is a very relevant and pertinent topic, as much as I think. Because in today's time, we feel and we have understood that patient safety is not a one man's job and everyone is a party to it. So I believe I'll be able to do justice to this topic in this shorter time frame. And without wasting any further minutes, let me deep dive into the topic. So it's about medication safety, integrating all the stakeholders. The very essence of medication safety is lying in the dictum of primum non nocere, which means first do no harm. This dictum is being carried over from the distant past and probably in years to come and even in future. And it was probably generated from the Hippocrates. At that time, therapeutics was not based on sound scientific knowledge and rational method. And the medicaments that were available were more likely to cause harm than being helpful. So the dictum has been in place since the past, has traversed its way through so many years, and is also leading our medication safety notion today. With this, the number of adverse events have also been on exponential rise over the decades. This may be attributed to the development of new medicines, discovery of new uses of older medicines, aging population, and increased use of medicines for disease prevention and treatment. The burden of unsafe medications has been huge, to that tune that 1 in 10 leading causes of death and disability worldwide. Its WHO statistics says that 1 in every 10 patients is harmed while receiving hospital care, with nearly around 50% of them being preventable. In primary and outpatient healthcare setup, 4 in 10 patients are harmed, with up to 80% of those harm being preventable. And most detrimental errors are related to the diagnosis, to the prescription, and to the medication use. 134 million adverse events occurred per year in hospitals in low middle income countries, resulting in 2.6 million deaths. In OECD countries, 15% of the total hospital activity and expenditure is a direct result of adverse event. So we understand to what extent, what is the magnitude of the problem. With this, over the years, there has been definitions in place, and the Agency of Healthcare Research and Quality has defined medication safety as freedom from accidental injury due to medical care or medical errors during the medication use process. With continuous evaluation of these medication safety practices, it is very much imperative for us to explore the viewpoints of the various stakeholders involved and the various stakeholders' knowledge, attitude, and practices towards mitigating the patient harm or the medication harm. So if we deeply analyze, the various partners in patient safety are healthcare providers, which includes doctors, nurses, pharmacists, hospital administration, pharmaceutical companies, which are having R&Ds in place, clinical safety team, government bodies, national drug regulatory agencies, national pharmacovigilance program, and the accreditation bodies. And last but not the least, consumers, which includes the patients, the caregivers, the family members, and also the consumer rights protection bodies. As we understand that effective medication management is a complex interplay of various disciplines, there should be a collaboration between the healthcare providers like doctors, nurses, and pharmacists who are working with the common goal of maximizing the patient safety, maximizing the patient's benefits, and minimizing the patient's harm. So the medication management is, in short, a coordinated interplay. And each and every healthcare provider over here has either an independent role, a joint role, or an overlapping role in managing the patient, in managing the safe medication practices. As we all know that the medication use processes starts with prescribing at the first go, but it's not a single step process and it's a multi-step one. So it starts with prescribing, then we have documenting and transcribing, we have dispensing, administration, and monitoring. So if we go for the first one, that is the physicians who are the prescribers. We know that the prescribing medications is the main approach in the treatment strategies. This is an accepted fact that while all the medicines that are prescribed, they have a beneficial effect on the health status. With this, each and every medications also come with an inherent potential to cause harm if used inappropriately. So the physicians have at some point of time the bestowed responsibility, they have recommendations in place that should underpin the safety, or that should underpin the safety of the medication practices or safe medication usage. So to prevent the harm or the atrocities that is caused due to unsafe prescribing practices, doctors should follow good prescribing practices. And as Professor Ray said, that he very well highlighted these points that we have in this present slides regarding good prescribing practices, using of generic names where appropriate. Indian Medical Council regulation of 2002, it stated that every physician should be, as far as possible, prescribe drugs with generic names, and he or she shall ensure that there is a rational prescription and use of drugs. Use of capital letter policy. As an amendment to the earlier act that I said, it was mandated for all the doctors to prescribe drugs with generic names legibly and preferably in capital letters. All these measures are to ensure safe prescribing practices, such as to mitigate the harms that can occur due to unsafe prescribing or illegible handwritings in the prescriptions. Patient-tailored prescribing. Prescribing must be tailored for individual patients. It's very well accepted that treatment are not a one-size-fits-for-all. So individualizing the treatment can ensure better and much safer outcomes, thereby reducing the chances of side effects. Then we have thorough history taking. When we speak about history taking, each and every information that is gathered from a patient, some way or the other, crucially guides and directs the care. Medication history taking includes patient's past history, surgical history, if any, patient's family history, social history, allergies or medication allergy histories, if any. Then what are the medications that the patient was taking, or what he is taking right now, or what he has stopped recently. All these sort of bits and pieces informations not only help to gain knowledge, but also help to prevent the harms or the atrocities that could be caused due to the treatment-related practices. Then we have the use of standard abbreviations. Standard abbreviations, as we all know, that it helps in increasing the speed of note-taking in case of the patient's bedside. But its overuse can be detrimental. It can cause patient harm because the non-standard abbreviations not only increase the misinterpretation, but can also lead to confusion or repetition of the orders, which is very much harmful for a patient. Next, we have the protocols for high-risk medication. High-risk medications are those drugs that have the heightened risk of causing patient harm when used in error. So there should be protocols in place. There should be a protocol for its storage. There should be a protocols for its use, and people and the healthcare providers should be trained on it. Then we have a concept of tall man lettering. Tall man lettering is a typographic technique by which that uses the selective capitalization of certain letters such that the look alike and the sound alike medications can be differentiated. Then we have a clear communication. Clear communication is the essence in any medication safety program, because a clear communication between all the stakeholders, the physicians, the nurses, the doctors, the pharmacists, and the hospital administration, each and every stakeholder, a clear communication between all can help to mitigate the harm to a large extent. Ensuring double checks. Physicians can also encourage the patients to be a party, to be actively involved in the medication management process. Physicians can also report and learn from the medication error. There is a no blame, no shame policy should be in place. One should not be afraid to report the medication errors for the fear of being punished or any other legal processes, but should freely report and should freely learn from them. With this, we come to the next. This is a newspaper chronicle which shows that there was a reporting that it's time to totally ban handwritten prescription. However, the same is very challenging for setups like India, where access to healthcare is still challenging at various parts. But the newspaper cutting reads out that from the perspective of patients, illegible handwriting in prescription writing is a nuisance, which could result in serious injuries, including death of the patients. It may compel patients to take wrong medicine and wrong dosage, and can also lead to unnecessary tests and discomfort. Pharmacists may dispense the wrong drugs. Now we come to the next stakeholder. While we know that the physicians make the diagnosis and the treatment decisions, but there exists a challenge. They spend very less time with the critically ill hospitalized patient as compared to the nurses, who are a constant companion at the bedside. And being the constant companion at the bedside, they can very critically monitor the patient for clinical deterioration, and they are the first person who can identify and communicate the same to the physician. So they play a very crucial role for timely coordination and communication of the patient's condition to the medical team. Nurses, being the administrator, is also bestowed upon the responsibility of labeling the medications before administering. Various surveys shows that a lot of medication errors attributed to the nursing activities do occur between the handover time, when nurse A, who is signing off, gives the drug X, and the nurse B, who is in the next shift, does not check the same and again gives the drug X. So the cross checks and this thing should be much taken care of, and should be people should be very much vigilant about that. The nurses should also have continuous training and updating on LASA and high-risk medications, that is look-alike, sound-alike medications. There should be continuous training, updating the lists, the separate storage facilities, how it is being stored. These things should be well updated and they should be trained from time to time. We all know about the rights of medical administration, the 5 rights. Here we give you a glimpse of the 8 rights. Right patient, right medication, right dose, right route, right time, right documentation, right reason, and right response. While right patient, the nurse should check the name on the order and the patient. The patient may be asked to identify himself or herself. For giving the right medication, the right medication label and the order must be checked. Right dose, the order should be checked and the appropriateness of the dose should be confirmed using a current drug reference. If necessary, the drug can be calculated and in presence of another nurse. Right route, the order should be rechecked and the appropriateness of the route ordered should be confirmed from the patient, whether he can take up that route of medication or not. Right time, the frequency of the ordered medication should be checked. Double check that you're giving the ordered dose at the correct time or not. At the same time, confirm when the last dose was given. For right documentation, the documentation should be done after the ordered medication has been given. Charts the time, route, and any other specific information as necessary. Right reason, confirm the rationale for the ordered medication. Revisit the reasons for long-term medication use, whether the medication is still required or not. Consult the physician, speak and interact, and then find out whether the medication is still needed to be given or not. Right response, make sure that the drug leads to its desired effect. You're giving an antihypertensive drug, the response is not optimal. Connect to the physician, convey it to the physician. Be sure to document monitoring of the patient and any other nursing interventions that are applicable. With this, we come to the other stakeholder, an important stakeholder, the pharmacists. Pharmacists in our setup are mainly of 3 kinds: the community pharmacists, the hospital pharmacists, and the clinical pharmacists, wherever placed. With all these pharmacists have the common goal of ensuring the access to the right medication for the right patient. For pharmacists, it's very important that a registered pharmacist is placed in a pharmacy shop or in a dispensing area. Pharmacists can supply the medication information to the patient. In case of self-medication practices, as Professor Mondal said, in case of self-medication practices at the community level, pharmacists are at the crucial point where he can convey what are the medication related adverse event that can cause, what can be the side effects, how long he needs to take the medication to ensure the medication usage, the proper medication usage and safer medication usage. In case of self-medication practices, he can also evaluate whether the medication is appropriate for the patient's condition or not by history taking of the patient. So the medication appropriateness can be evaluated and ensured by the pharmacist at that point. Pharmacists can also help in improving the medication adherence by educating the patient regarding the safe medication, regarding the medication needed, the rationale for that medication, how long the medication is to be taken. The pharmacist should be trained periodically on the hospital formulary if available and good pharmacy practices. Pharmacists being in the ready disposal or in the very direct patient contact in the community setting, he or she can be the first person to report the adverse events, because those adverse events coming out from the grassroots level can increase the area frequencies and can help us to detect the signals. So pharmacists should also be trained on the LASA and the high-risk medications and should be particularly trained where to store the look-alike and sound-alike medications and the high-risk medications, such as to prevent the atrocities. Now we have the another stakeholder, who is the hospital administration. The hospital administration should have a hospital formulary at place, a hospital formulary with which each and every medication healthcare provider should be trained about. They should be trained on the hospital formulary, the use of the drugs, and the conditions where it is. So the medication safety board should be created by the hospital, which should have an interdisciplinary participation. And the medication safety board should be well communicated. Any medication errors, any medication related events can be communicated to the safety board and will be dealt with the board in the clearest time. Hospital administration should also have a policy in place for regular prescription and clinical audits. This can help the hospital administration to have a better overview of the practices that is prevalent in the hospital. Hospitals should develop a blame-free and punishment-free culture of medication error reporting, such that it follows a policy of no blame, no shame, and anyone can feel free to report the errors if it occurs. Now we have the pharmaceutical companies, who are a very key partner in the medication usage, medication safety process. The goal of the pharmaceutical companies is to maximize the safety of their product, maintain the public confidence, and for this, they proactively assess and manage the risk associated with their drugs throughout the drug's life cycle, from the development to the post-marketing phases. During the development, during the phases of the clinical trial, they submit details of the adverse event to the regulators in a specific time frame basis. They also notify the investigators and also the ethics committees. Their reports are also reviewed by the independent bodies like drug safety monitoring boards. Whatever in the drug clinical trial phases, post-approval phases also is very much important for the safety monitoring in case of the pharmaceutical companies. The safety is their main obligation from their point of view. So they have phase 4 clinical studies, which can be clinical trial or pharmacoepidemiological studies. Then they have risk management plans, periodic safety update reports, and spontaneous reports. The framework of pharmaceutical companies is such that each R&D international companies have dedicated global clinical safety team that oversees the regulatory requirements, signal detection from area reports, and performs the trend analysis. The local office of the R&Ds, that is the medical affairs division or the regulatory divisions, looks into the local pharmacovigilance plan and coordinates with the global team. So the pharmaceutical companies collect, investigate, and proactively evaluate the information relating to the side effects of the medicines during the clinical trial phases, vigorously monitor the health outcomes, report the regulators on a time-to-time basis, and updates the safety leaflet according to the benefits of the consumers. Next, as we discussed, government bodies. And government bodies can be divided into 3 major bodies, like the National Drug Regulatory Body, the Pharmacovigilance Authority, and the Accreditation bodies. First, we go for the regulatory bodies. That is the CDSC. In our country, CDSC is the apex regulatory authority for the drug approval, and it is committed to safeguard and enhance the public health by assuring the safety and efficacy and quality of the medical products manufactured, imported, and distributed in the country. CDSC also issues periodic data safety alerts and records, which includes serious adverse reactions, including deaths. And CDSC also helps in a systematic safety reporting during the clinical trial via SOGAM portal. Next, and a very important key stakeholder is any nation's pharmacovigilance authority. For us, it's Indian Pharmacopoeia Commission. Indian Pharmacopoeia Commission is an autonomous body under Ministry of Health and Family Welfare, Government of India. IPC was created to set the standards for drugs in the country. Indian Pharmacopoeia Commission publishes IP, that is Indian Pharmacopoeia, which is a monograph that prescribes the standards for identity, purity, and the strength of the drugs that are marketed in the country or manufactured in the country. IP standards are authoritative in nature also. But the CDSCO are enforced, they're enforced by the regulators to ensure the quality of the drugs in the country based on the IP. IP also, in Pharmacopoeia Commission, also promotes rational use of drug practices by publishing the National Formulary of India, which is a ready reference book for all the healthcare practitioners. Indian Pharmacopoeia Commission has a Pharmacovigilance program in effect. It was launched with the broad objective of safeguarding the health of around 138 crore people in the country by monitoring the areas, reporting the same, and helping the CDSCO in making safety decisions regarding safe medication usage. PVPI now has close to around 500 area monitoring centers under its canopy, which collects the reports, processes it, and coordinates to the National Coordinating Center at Ghaziabad. PVPI has brought into effect various reporting forms for both healthcare professionals and the consumers. They are encouraged to report any adverse drug events, any adverse drug reactions to the nearest area reporting center following these formats. PVPI has also translated the medication safety reporting form for the consumers in 10 different regional languages for the easy comprehensibility of the consumers, the patients. And the program has also brought into effect a mobile application, which is an Android-based mobile application downloadable from Google Play Store to enhance the reporting statistics. And helpline number has been put into effect to provide assistance in area reporting by the HCPs as well as the general public. The toll-free number is operable from Monday to Friday, 9 to 5. And then we have accreditation bodies, as we heard from our last speaker. The National Accreditation Board for Hospitals and Healthcare Providers is a constituent board of Quality Council of India. NABH is committed to the cause of the patient safety and quality care. NABH sets various standards, and these standards focus on the patient safety and the quality of the service that is provided by the hospital, making the hospitals more safe and organized process of intervention. So the quality of care is maintained through various written standards, various written guidance documents, which focuses on availability, safe storage of the medications, prescriptions, dispensing, administration of medications. Everything is governed by the Quality Council, by the NABH written documents. So last but not the least, we have the consumers, the patients, the families, and the caregivers. Patients are always at the center stage. Why? Because they're the first to notice any observable problem from the medication usage. The evidence suggests that most of the patient-reported adverse reactions are very much accurate. They are that pretty accurate that they give a detailed description of the reaction that has come into place. However, it has been noted that patients do not report all the problems that they face. They only report the ones they find it to be the severe. So to implement a very much patient-centered pharmacovigilance, a patient should be educated by various educational interventions. It can be in the form of training programs. It can be in the form of leaflets, community seminars, anything. They should be educated. They should be enabled. They should know where to report, how to report, whom to report, and what is the mechanisms, what should happen to me if I report. and everything. They should be encouraged to report. They should be made felt important that they are in the center stage of the pharmacovigilance. They should report and they should be engaged in the patient reporting. And to play all this role, we can also have the social media in place. So social media also play a very important role where we can disseminate the information and it can reach a larger population than expected. So we have the last stakeholder, that's the consumer rights protection agencies. We have various consumer rights protection agencies which fight for the illegal online pharmacies, which fight against the illegal online pharmacies, and has given initiatives for better patient access for safer healthcare. One such organization is Patient Safety and Access Initiative of India Foundation. It's in the partnership with the Safe Medication Indian Initiative and has a toll-free number and is actively working throughout the country, pan-India, for fighting for the rights of the patients. So to have a patient medication safety in place, a pyramid should be built. The pyramid that we have in our left-hand side, all the levels are not mutually exclusive, but each issues can be addressed by any of the stakeholders, and there can be an overlapping of the responsibilities. So the developing and the enhancing of a culture where medication safety thrives, a safe culture, is the base of the pyramid on which the entire medication safety is based. And use of the information that comes up helps us to direct our future activities, future strategies. Influencing the practice changes to improve the patient safety can lead us to reach the tip of the pyramid, which is the patient safety. We weave from the top, but actually the base of the safe culture is very much important. With this, we have a WHO graphic which places patients at the center stage. Patients being in the center stage, there is 5 moments of medication safety, where a patient starting a medication should know what is the name of the medication and what is it for, what are the risks and the possible side effects. Taking my medications, the patients ask, when should I take this medication and how much should I take this time? What should I do if I have a side effect? Adding a medication, do I really need any other medication? Can this medication interact with the medications I'm already having? Reviewing the medication, how long should I take each medication? So now I'm taking a medication too long that I no longer need. And stopping medication. When should I stop the medication? If I have to stop my medication due to an unwanted effect, where should I report this? So the successful implementation of the patient safety strategies needs a clear policy in place, a leadership capacity, data to drive the safety improvements, skilled healthcare professionals, and effective involvement of patients in their care. The Government of India has put forward a National Patient Safety Implementation Framework Plan from 2018 to 2025, with various key areas, key priority areas, including structural system for quality and safety, assessment and reporting of adverse events, competent and capable workforce, control of healthcare associated infections, strengthening patient safety across all the programs, and promoting patient safety research. So with this, I come to the end of my presentation, and I profusely thank everyone for this platform. Thank you.
Thank you very much, Shatavisa, for this wonderful deliberation. So we are really enriched with your excellent talk. So with us, we have Dr. Shabnam Ara Begum. May I request Madam, because she is a very noted clinical pharmacologist and she is running the Department of Clinical Pharmacology at Archicor Medical College. So may I request Madam to say a couple of words.
Good afternoon, everybody. It is very nicely presented by Shatavisa. Actually, I have missed the first two topic, but I hope that is like both the speakers are like they are very good, and I appreciate that. And in Arjikot Medical College, like any other medical college, we have that is AMC Advanced Drug Monitoring Center, and our associate, that is the Pharmacovigilance associate, is working very hard, and we are actually running one therapeutics clinics or clinical pharmacology OPD. Now it is once in a week for last 1.5 years, and in that OPD also, the that is the Pharmacovigilance associate, he actually he's sitting with us, and we on the spot we reported many of the cases. If that in one day, like it is referred patient, no direct that entry card, or it is not now it is in the process. It is only referred from different clinical department. We actually reconciliation medication reconciliation drug of the drug are given, like drug-drug interactions, and also ADR or any kind of polypharmacy. If we can like reduce the dose, that we have done. Along with ADR, we actually like reported. So and our also make the awareness among patients and caregivers, like how to like they can actively involve in it. So in this era or in this like scenario, it is very much needed, like patient safety awareness, pharmacovigilance. It is very much needed, and we like physicians or clinical pharmacologists and pharmacologists, we should like collaborate with clinicians, and this awareness program should be incorporated to all levels, like physicians. Many of the physicians till now, they did not know, or they don't like know what is it. They have that fear that if we if we report that my prescription will be scrutinized, so I will be in the trap. So that awareness program we're starting like in physicians, like next week or next 1 or 2 weeks, we will like different kind of awareness program we will do, like first of all in the faculty group, then PGTs, then nurse and pharmacists. This kind of planning are there, and like last year also we are doing some kind of like awareness program to PGTs and also the nurses. But and it is like the response is good. From previous like year, the number of that is the reporting is increasing. So it is very much needed, and thank you all, all the presenters. They're like last year. Actually, I have heard only the Shatavisa's topic. That's all. It is very nicely like covered, and she has done justice to this topic. Thank you, everyone.
Thank you, madam, for your insights. And actually, you had again given that thought that we pharmacologists or clinical pharmacologists need to have some extra responsibility. That means apart from academics and research, we have to explore this very important domain, that how to ensure patient safety by having this type of works like clinical pharmacological reconciliation, review, feedback, and also how to manage, how to approach, how to diagnose drug-induced disorders. So thank you, madam. And now may I request all the other delegates who are still present with us, if you have any comments or any question, you may unmute yourself and you can raise your voice. Okay, so there is no more comments. So it is time to say that is goodbye for today. So we have to finish today's session. We are really thankful to our president, Professor Tapan Kumar Mondal sir, for continuously inspiring us for organizing this type of CMEs. We are really thankful to all the respected faculties, Professor S.M. Nasir, Professor Prabhuti Mondal, Dr. Chiranjib Bagchi, Dr. Subhrojyoti Bhowmick, Professor Krishnangshu Ray, Dr. Shormila Nath, Dr. Mondal, Dr. Subhash Mondal, Professor Indranil Vishwas, and Shatavisa Mukherjee. And also we are really thankful to Professor Partho Ray from UK and Dr. Shabnam Ara Begum, who had given their thoughts on this very important topic. So with that, I thank you all. We will meet surely in the next academic meeting, and hopefully we are organizing by 17th of September. We all know the World Patient Safety Day, and on behalf of Indian Pharmacological Society West Bengal Chapter, we are definitely going to organize a hybrid mode conference on this very important issue. So again, I want to thank you all, and bye-bye.